Welcome to PEM CHATT. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. All right, welcome back to PEM CHATT. I'm glad you guys have decided to join us today. We are going to start a two-part series with our clinical pharmacists. We are incredibly blessed to have two pediatric clinical pharmacists that work in our department almost all the time. Of course, you're not there in the early morning when I get there, but we have Maggie Raker and Morgan Padron with us today, and we're going to be talking today about antibiotics. Truth be told, we started this podcast a few weeks ago, and we talked about a bunch of other medications, and that's going to be part two. But we're going to cover the antibiotic portion first. But before we talk about these medications, tell us a little bit about yourself, ladies.
Hi, I'm Maggie Raker. I've been a pharmacist now for 5 years, which is wild. I went to Ohio Northern University, and then I did a residency at Memorial Health University Medical Center in Savannah, Georgia. Long name. And that residency was in adults, but after residency, I moved into their pediatric hospital, and I was in a position where I would work in the pharmacy, but I would also do coverage on PICU, NICU, and a little bit on Hem/Onc. And at that hospital, we didn't have a specific ER pharmacist. However, we would go down or help out as needed. So from there, we were just ready to get a little closer back to home. So I kind of put my visions out for jobs that were posted and saw a position at our hospital in Chattanooga and ended up as the first brand new children's ER pharmacist at this hospital, and kind of helped create that position with my manager and all of you guys. And then we brought Morgan on after. Outside of work, I like to sew and garden and parent my two crazy kiddos.
Yeah. Do you like to sew? What's your Instagram handle?
Oh, no. My Instagram is at Magdalene with one N makes.
Yeah, it's so cool. It's fun to watch you make all this stuff at home.
It's so awkward to post on there, but here I am doing it.
Oh, I love it.
Featuring this outfit right now. This outfit.
I think it's fantastic. You have to have hobbies and things you do outside of work to stay happy and focused. So I think it's awesome. All right, Morgan, tell us about you.
My name's Morgan Padron, and I have been a pharmacist for about 4 years now. I went to the University of Georgia for undergrad and for pharmacy school, so go dogs. And I did a 4th-year clinical rotation down. I did all my rotations down in Savannah, but one of them was at the hospital that Maggie was doing residency at. So she precepted me for a rotation, which was cool. And that's kind of how we got to know each other. I went off to Memphis, Tennessee, and did a PGY1 at Le Bonheur Children's Hospital. And it was kind of very peds focused. And then after that, I moved to Kansas City, where I took a maternal child clinical position where I rotated between PICU, NICU, Gen Peds, maternal medicine. And then we did have a ER specific pharmacist, but they were not peds trained. And so anytime a OB patient or peds patient came into our emergency room or trauma bay, we would usually respond to those. So that's kind of where I got my first taste of ER experience outside of residency. And then when Maggie told me that she was moving to Chattanooga and taking this job, I was like, ooh, tell me if there's any positions that are open, because I've always wanted to live in Chattanooga, and we wanted to move closer to home since me and my husband are from Georgia. And she was like, well, my position's supposed to be 7 on, 7 off, so I'm going to need a counterpart. And the rest is history. Here we are. I've been in this position for a little over a year now.
It's amazing. It's awesome to have you guys. I didn't have a lot of experience with clinical pharmacists because in the majority of the places I worked, we didn't have one. So it's kind of a new thing to me. Tell us what clinical pharmacists do.
So a clinical pharmacist is a pharmacist that's more focused on helping the practitioners, I guess, and the nurses. So while we do go into the pharmacy, we're kind of owned by the pharmacy. We help out dispensing sometimes. We are mainly on the floor, sitting in the ER, working with you guys and the nurses, and being more direct with the patients. So I'll let Morgan talk about kind of our day-to-day, but a clinical pharmacist is a pharmacist that is just more integrated into the team And I want to say that with caution, because our staff pharmacists do help out when they're called and we're not here and you guys call out, and they're definitely able to like answer questions and help. But we are just more meant to be in person, working with you guys in the team, more in the like literature and guidelines, kind of helping to guide treatment plans rather than just like making sure it's safe and reasonable, I would say.
Yeah, and I think that's a great description because the pharmacy lives in pharmacy land, wherever that is in the hospital. It's moved around and I don't even know where it is anymore. But I think it's intimidating to call this person in a room somewhere. You don't know them, you don't have a relationship with them, and you don't really know what you can or can't ask. I'm sure some people are more comfortable picking up the phone and calling the pharmacist than others. But I will say this, having developed a relationship with both of you in a clinical setting has made me oodles more comfortable with pharmacists in general. Like when you're not there, I'm more apt to actually call the pharmacist now than I was before, because I'm like, oh, well, they're part of my team and I can just call and ask my teammate. Before we had that relationship, it was a little intimidating. And so I was probably more apt to like jump into UpToDate and look something up than call a pharmacist. And now I feel like I just call the pharmacist.
Yeah, they're happy to help as well too. They, like to know what's going on and want to be there and help too. So they're always a good resource.
Yeah, I think it's fantastic. And you guys help with traumas and codes and
our specific role, we come in the afternoons just when it's a little bit busier in the children's ER. And I would say like 70 to 80% of our job is answering questions from providers down there, whether it's antibiotic coverage or what's the best agent that I can get outpatient. We help a lot with trying to figure out if you're going to be able to actually fill it at a CVS or Walgreens, because there are a lot of suspensions that, yes, they make them, but you're not probably going to be able to find them. We're trying to figure out, like, can we crush a tablet and how can we get it to the patient where they're not going to have a delay in care once they leave the ER. We also answer a lot of questions about administration and preparation of medications. I think we're usually helping nurses a lot with diluting or reconstituting medications, getting it set up on the pumps to make sure it runs in a safe manner, that it's compatible with the other things that are running. And then the other 20% of our job is attending codes and traumas. So anytime a level 1 or a level 2 trauma comes in or a critical medical patient is moved to the trauma bay, we're going into the bay with the nurses and with the providers, pulling the meds out that we need, and then helping draw those up so they're in a administration ready form for the nurses to give. But then also a lot of times we're figuring out dosing as well. And so the providers are just calling out like, hey, I want calcium, I want epi, I want bicarb, and we're figuring out what the correct dosing is as well. And then drawing that up for the nurse to administer.
Yeah. Thank God for a pharmacist. That's awesome. I can remember 20 plus years ago when I was a nurse in the children's ER, we had to mix our own drips in codes. And I remember getting, a request for an epi drip. And I was like, oh my God, this is, incredibly overwhelming in a really high pressure environment. So I can't imagine how awesome it is to have a pharmacist sitting there that can help you with those things.
Yeah. And of course the nurse has like 500 things to do. So it's just nice for us to focus on like what we know best and what we do, not every day, but like are studying every day almost, and to be able to just like take the pressure off of them.
Yeah. And I think we also have done a good job of trying to make sure that we provide a lot of education for the nurses as well, since we aren't there 24/7. So sometimes they are running codes and traumas without a pharmacist present, making sure that there's resources and things that they can reference so they're not having to just go off the back of their mind. And they have papers there that tell them kind of like what the dosing is for that specific patient's age or weight, and how to prep and mix things too.
Yeah, it's fantastic. I did a little sedation the other day for an LP, and Maggie sent the nurse all the
bugging her.
Well, you sent her all of the volumes for the different dosing, and you helped her set all of that up. And so she came in and she had everything ready to go and pulled up in these separate vials. It was great. It ended up being fantastic. So I think that's an awesome resource. So thank you guys for being there. All right. Well, today we're going to try to tackle antibiotics. And this is a big topic. We talk about it all the time at work. All right, guys, I wanted to jump in here for just a minute and talk to you about a few things about the antibiotics guide that Maggie and Morgan have provided for us today. Now, this really goes back to their roots in pharmacy school and how they learned antibiotics. So they start here with the ID man. Now, he's here on the screen. So if you're joining us on YouTube, you can see these things in real time. But if you're not and you're listening on Spotify or Apple or one of the other sources, you can always access these links in the show notes. But basically, our ID man looks like a little gingerbread man, and he is an illustration of the human body. And Maggie has written on here the different bacteria that very classically affect these different body systems. And so it really takes us back to that organic thought process of what am I treating? What are the most common bacteria there? And then how am I going to pick a drug that covers those bacteria best without covering all the bacteria, right? Like, let's keep it targeted to the things that I want to treat for this particular patient. The next several pages are basically a handwritten guide showing you what different antibiotics treat. And I think this is a really great illustration for us. It's not something you can memorize, but it's a great reference to look at and a guide to help you understand how different things broaden or change coverage. So, for example, in the cephalosporins, she goes through all of the 1 through 5 generations of the cephalosporins, and you can see how they broaden or change between the classes. So it may be a good guide to help you, maybe scale back your antibiotic choice for a simple cystitis, or maybe broaden your coverage if you're going to treat something that, in a patient, they may have something that's more resistant. So if you're anything like me, in school, they give you all this information in one giant brain dump, and it's just basically a memorization game so that you can get through your tests. But it's really hard for me anyway, to remember that stuff until I put this into clinical practice. So it's really been an iterative process over years for me to understand this stuff. And there are still things that I go back and I can't pull out of my memory bank because I don't use them. They're not things that I'm using on a daily basis. So, for example, meropenem, somebody was using that in the ER the other day, and I don't think I've ever prescribed that medication. So I had to really kind of look back and say, what am I treating with this medicine? Because I don't use it regularly. So if you're at a place where you're ready to go take another dive into the pathophysiology of antibiotics, and you really want to do a deep dive and learn this stuff again, or refresh your memory, or maybe learn it on a deeper level, I did find a really cool resource out there. I have absolutely no financial disclosures here or no connection with Ninja Nerd, but I did think that this 2-hour lecture on YouTube was really outstanding. And he taught all the different patho for all the different antibiotics. And it really reinforced some learning for me and refreshed me on a lot of things that I'm not using on a daily basis. So I encourage you to go to that link and watch that video if you're at a place in your career where you're ready to do that deep dive again and kind of refresh this information for yourself. All right, guys, now we're going to shift gears and get back into the podcast with Maggie and Morgan. And for the remainder of this podcast, we're going to be talking about the antibiotics that we choose for common things we see in the ER. So let's talk specifically about how we treat certain things. I thought we'd go through some of the most common things that we see. Ear infections. We see this every single day. How do we treat this typically, Maggie?
So you're looking at your strep pneumonia, your H flu, and your Moraxella for the most part is the organisms that are most likely to cause ear infections. So in the ear infection guidelines, your first line is going to be high dose amoxicillin. So that's 90 mg per kg per day divided twice a day. That's your really hard hitter, your first line, unless you have a true allergy or you have a history of ear infections or a recent ear infection that wasn't treated by amoxicillin. With those, you could...
Sorry.
Yeah. No,
what I feel is changing here is the duration of treatment. When I went to school, it was 10 days to treat this, regardless of the child's age. Where are we at now?
So the most recent acute otitis media guidelines, I think they're from the AAP, but I don't want to quote myself. They have a good length of treatment statement in there. So less than 2, and children with severe symptoms, you're going to do your 10-day course. 2 to 5 years, a 7-day course might be okay with mild or moderate AOM. So that's peeling back a couple of days. And then for children 6 years and older with the mild to moderate symptoms, a 5 to 7 day course could be used.
And I'm kind of moving toward that 7-day. It's hard to, change those habits that you're in. But you have better compliance when they're shorter anyway. So, okay.
So next step in that algorithm, again, if they have a infection that wasn't treated by the amoxicillin, or if they have within the last 28 days, or they have just chronic recurrent, you can move on to the augmentin, which just gives a little bit wider of coverage. Dosing is the same, 90 mg per kg per day, divided twice a day. And then those are the good ones. I guess an IV or IM option is ceftriaxone that we could do. But then down your algorithm of either we've tried all these other things and they don't work, or they have an allergy to amoxicillin. You have ceftonir, azithromycin, or clindamycin. But those just as a whole aren't going to work as well as your really hard hitter amoxicillin or your augmentin. And then a little note on this, which gets really confusing. Actually had a big talk with one of our doctors about it last night, just because it is so confusing. I'll try to make it more succinct, is the augmentin dosing. So there's different products of augmentin. There's different ones to choose, but the easiest way I think to think about which product to choose is if you're doing high daily dosing of augmentin, so the 90 mg per kg per day that you're going to choose in acute otitis media, you're going to use the 600-42.9 per 5 ml, and that's going to give you the correct ratio of the clavulonate portion of augmentin. That's kind of the easiest way to think about it. High dose is the 600. Now, if you're doing like 50 mg per kg per day dosing for skin and soft tissue infections, it's a lower total daily dose. You're going to use the 400-57 per 5 ml, and that gives you the correct ratio of the clavulonate portion. Too much of that can cause diarrhea, which this drug already causes, so we don't want to cause more. Too little of it might not be as efficacious as it needs to be.
Okay, UTI. We're going to talk about urinary tract infection, probably the second most common thing we treat in the ER.
Yeah. So for UTIs, typically the biggest bug you're thinking about is E. coli. But other than that, you can have some other gram negatives. So Klebsiella, Proteus, maybe Enterobacter, Citrobacter, but those are not nearly as common. For gram positives, you might see staph, Saprophytic.
That was good.
I feel like we've seen that one a lot more recently. Enterococcus, and then rarely you might see Staph aureus. So for that, your antibiotic choice is really going to depend on what you're treating and if you have a culture or you have previous growth from that patient. So if it's like their very first UTI, they're not like they don't have like a complicated GU or GIGU system anatomy, then you're really just thinking like gram positives and maybe some E. coli. But if you're thinking just gram positives, you can use Keflex or Cephalexin because it gives you great gram positive coverage. You can go with higher dosing if you're treating pyelonephritis, but usually if they have pyelonephritis and they're a peds patient, they're going to be more complicated and need something with broader coverage than just Keflex. If you need gram negative coverage, then ceftonir is a great option. So that oral third generation cephalosporin, and that can be given once a day or twice a day. I like doing once a day dosing just because it has better compliance for patients.
Twice a day. But I'm like, yes, why?
And I prescribe it based on who's there. No, I'm just kidding. But it's nice to know that you could potentially increase your dose of 14 mg per kg on the ceftonir and do it once a day. It's so nice. But my personal little hang up with this medicine is if you don't tell the parents that it can make their poop red. Like, please, 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 if you prescribe this drug, tell the parent that their poop could potentially look like they're bleeding. It's more like a brick red, so it's a little different. Doesn't really look like true blood in the stool, but boy, I've seen it and it's concerning, and we get that a lot in the ER. I feel like a lot of people don't tell parents. I'm sorry, I interrupted you.
No,
that's a great.
That's what I always forget is a side effect of it, and it's always so weird to me because there's no part of ceftonir like capsules or suspension that is red.
Right.
I think it mixes with iron and causes that red color. So especially in babies on formula that have added iron to it, that might be where you see it a lot, or someone taking an iron supplement. A nurse texted me the other day and was like, hey, my kid's taking iron. Doesn't that do something weird with ceftonir? And I was like, yeah, you could just separate them by a couple hours. Like, don't give them together in the stomach. But yeah, you might see the red poop there.
That's interesting. I don't think I'd thought that through because it's generally a baby that's still on formula that comes in. So yeah, good thoughts.
Yeah.
Outside of your ceftonir and Keflex, so your cephalosporins, you might see nitrofurantoin. So in those teenage patients that don't have any other complications, so just truly a UTI, not anything pyelonephritis, and really just females, I think. I don't know if it's moving towards, I think adult world is moving towards some male UTIs are not considered complicated, but I haven't dug into that research, and it's always takes a lot longer for that to trickle into the peds world. And then with Enterococcus, amoxicillin is going to be your hard hitter because Enterococcus is innately resistant to all cephalosporins. So cephalosporins are not going to be your preferred therapy there. It's going to be amoxicillin or augmentin. For length of treatment, kind of depends. There's not really clear-cut definitions of complicated versus uncomplicated UTIs in pediatric patients like there are in adults. But if you are thinking they're otherwise completely healthy, it's not complex or anything like that, probably a 5-day, maybe a 7-day course would be adequate. And then for patients that are less than 2 years old, or have any other like complications that might make them more of a risk to be a treatment failure, you might want to do closer to like a 10-day course. There's some guidance on like less than 13 years old, you could potentially do 3 to 5 days. For females who are greater than 13 years old, also 3 to 5 days. And then for male children who are greater than 13 years old, 7 days. So it's a big wide range, and I have to look it up every time someone asks me what our treatment duration is, but anywhere from 3 to 10 days.
Yeah, there's a lot of different opinions between different pathways. There's not a great guideline, and then the different up-to-date age groups that they group the UTIs into.
And the same thing goes with children as adults. Like it'd be unusual to have a urinary tract infection if you don't have some history there, right? So especially in adolescents, you need to broaden that and think about STI coverage too. Let's talk about pneumonia.
So overall, we're thinking strep pneumonia, H flu, Moraxella, Catarrhales, and Patagon as our like community-acquired pneumonia bugs. This last year, we also saw a lot of the mycoplasma, as I said, so that was something that was on everyone's mind. We started just kind of covering it in almost everyone.
Double covered everybody, yeah.
And every patient almost that had the specific test for it. And then hospital-acquired pneumonia, again, Morgan said you can think community-acquired versus hospital-acquired, had prior hospitalizations. So those hospital kids, we think Staph aureus, MRSA, maybe a little strep, and then your bigger gram-negative bugs, so maybe adding Pseudomonas coverage. This is how I like to think about it too when we're treating. So you have your simple kids who are getting discharged home, have never had a pneumonia in the past, don't have healthcare risk factors. So your outpatient treatment, again, your workhorse is going to be amoxicillin. So the high dose amoxicillin, the 90 mg per kg per day. This one you could divide twice a day or 3 times a day. Again, twice a day is going to be better with compliance. Clindamycin's another option if you want a little bit of wimpy MRSA coverage or you have an allergy to beta-lactams or amoxicillin. Then if we're admitting to the hospital and we're like going to the floor, we don't need extra respiratory support. Your ampicillin should be your first choice to think about, and that has a great strep pneumo coverage. That is what I try to guide people to if we're admitting to the floor service. If you are moving towards high flow intubation, ceftriaxone is a great choice for like your PICU kids, and they like to add that on if they're going to PICU, if they're serious enough to get that respiratory coverage. That's going to be your kind of bread and butter of those PICU pneumonia kids. And then moving past that, those crashing PICU patients, you're going to want to consider MRSA coverage, which would be Vanc or linezolid in them. And as we mentioned before, the mycoplasma azithromycin is going to be your hard hitter there to add on to your strep pneumonia coverage. So adding on azithromycin if you think it's one of, or the atypical pneumonia looking.
Yeah, and I haven't seen any this year. It's interesting. feast or famine there, man. We were treating everybody, and now I haven't seen a myco in quite some time. All right.
What would you do for Pseudomonas?
Pseudomonas, you would be going to cefepime. Usually, that's kind of your narrowest, but still covers Pseudomonas coverage. Zosyn could be an option, although that's a little broader. So if we can avoid it, we would like to. Do you have any?
No.
Different conditions.
I
And
was just
then
like, wait, we didn't talk about Pseudomonas.
you mentioned the post-flu pneumonia. So there are IDSA guidelines on like a more serious crashing patient with post-flu pneumonia and how MRSA can be a more common organism causing that. So again, you said clindamycin outpatient, but in these patients, you're going to want to consider the vancomycin addition to cover that MRSA or linezolid if that is your flavor you want.
Big guns for your crashing patients. So you call it the wimpy MRSA, and what do you call the other one? Big dog MRSA?
That's what I called it.
Big boy.
Big boy.
Or hospital MRSA.
Big boy MRSA. So there's a bunch of different studies that look at the short course of 5 days versus 10 days. So the study in 2022 found that a 5-day course was not inferior to 10 days in treatment of outpatient pediatric pneumonia in patients aged 2 to 59 months.
59 months.
So specific. So it is moving towards shorter coverage, looking at 5 days versus 10 days and the less severe outpatient coverage, but there is not a great pneumonia pediatric guideline to state that. So just using your up-to-date, using your CHOP pathways or whatever you're looking at to reference and kind of synthesizing, okay, what does my patient look like? How old are they? Can I get away with that shorter course is definitely a good thought to have.
Yeah.
While looking at the patient.
And I always wonder if they do the whole course anyway. You know, I prescribe 10 days, and if they get 7, I'm lucky. Okay, let's talk about animal bites.
Dog Augmentin, man.
Say.
Okay, so joking, but actually true. Your hard hitter for animal bites is going to be Augmentin.
Yeah.
Dogmentin, as we like to call it. So that's going to cover, you want to think about your skin organisms that are on your skin, as well as the organisms in the dog or human's mouth. So that should encompass all of those. You have the anaerobes. I know with human bites, you're looking at Echinella corrodens. That's always my fun fact, is what grows in human bites. And then your dog bite, what's this outfit?
Oh, I don't know.
Do you know off the top of your head what that organism is called in dogs' mouths?
Is it Pasteurella?
Yeah, Pasteurella in cats. So that covers that as well.
It's the 400, right? The 400? Okay. The lower concentration version. And if I'm remembering this correctly, it's 50 milligrams per kilogram twice a day? Or it's
50
divided?
mg per kg per day divided. Yeah. But that's right.
Yeah, for 5 days for a typical dog bite. But really, you're using this for any kind of bite that breaks the skin. So, you know, I just kind of think about it for all bites: human bites, cat bites, dog bites, all the bites. Don't leave the ER without your Augmentin, because you know they get infected even with this coverage. So we want to make sure we clean it really well and get them on an antibiotic. All right, cellulitis, another thing we see tons of, which I feel like is different. We definitely treat this a little differently than adults.
Yeah. So cellulitis, I think breaking it down into two main categories. So non-purulent versus purulent. So for your non-purulent, you're thinking like impetigo, so group A strep, Staph aureus. And for that, your big hitters are going to be mupirocin topical for like 5 days, or potentially Keflex oral for 5 days. For non-purulent cellulitis, group A strep, just like your staph strep like skin flora. With that, you can do Keflex for PO option, maybe Ansef or cefazolin for IV option. And then if they have a treatment failure, you could potentially move to clindamycin. For necrotizing fasciitis, that's where you're going to bring in those big hitters. So Zosyn or Vanc plus or minus clindamycin, because that gives you that toxin producing
coverage.
Yeah,
I
can't remember exactly what you call it. And then for staph scalded skin syndrome, you are looking specifically at an exotoxin producing strains of Staph aureus, and you're options there are going to be like oxacillin or nafcillin. And more recently, we've moved a little bit more towards cefazolin. And I know that's kind of what our ID people recommend and what they're using when they admit these kids to the floor. So they all have good coverage. The oxacillin and nafcillin are just hard because you have to give them like 4 times a day and they're expensive.
And they have like extravasation risks. So these kids are usually on the floor with the peripheral line, and it's those drugs, just if they extravasated, would be more caustic to the tissue. So that's kind of again why we've moved away from them.
Yeah, and the ANSEF doesn't even show up in the algorithm. This is just kind of something that we're doing in our own shop. So we're seeing that and treating with good success. We've had a run on staph scalded skin this week. So
it's
like all the twins in the city are covered in my stuff.
An incredible amount of staph scalded skin. Okay, what about a preseptal or orbital cellulitis? Now, of course, that's a big divide. But if we're going to just treat a preseptal and send them home, what are we going to put them on?
Yeah, so there you want to think about your skin organism, so the staph and the strep, and then you want to think about a little bit of the anaerobic coverage too. So your augmentin, is going to be your good oral version. But if we're admitting and we want to put them on IV antibiotics, usually the Unison, which is basically the IV version, is what we would start them on for the preseptal.
Yeah. And then if you look it up on Up to Date, they say if you have like an injury, a trauma, break in the skin, they add the MRSA coverage too.
Yeah, I think so.
So you have to do the augmentin with something else. Is it Bactrim? Pretty sure.
I think
the
so.
MRSA, yeah.
Yeah. And if we admit an orbital cellulitis, we're doing Unison. Is that what you guys are seeing on the floor too?
So if you're thinking it's orbital versus preseptal, you're thinking back to the ID man, like looking at those kind of oral and sinus flora and thinking that there could be some translocation, whether there's an injury or inflammation that allows those bugs to kind of move into that area. So you're thinking more anaerobic coverage.
Speaking of sinusitis, we're going to talk about this really briefly about how kids are not born with aerated sinuses. So we kind of jokingly talk about when people treat sinusitis in a 1-year-old. Do you really have a sinusitis? We now know most sinusitises are viral. But I'll put a picture of the diagram here on the podcast so you can see the progression of the aeration of the sinuses. So you're not fully aerated till you're between like 7 and 8 years old. So we always kid about people that treat sinusitis in little kids. But you can absolutely get a sinusitis. Sinusitis is the number one thing that actually contributes to this orbital cellulitis that we were just talking about. We've actually seen brain abscesses because of a sinusitis that ultimately infected the CNS. So yes, you can get sinusitis, but you're probably going to be a little bit older and not be a baby. But how do we treat a sinusitis?
That would be your hard hitter augmentin with the anaerobic coverage, and then your like strep, pneumonia, all of that stuff in there.
And if you're thinking admission and you want IV, then the IV formulation is going to be Unison.
And just to cover other things in this area, same drug choices for peritonsillar abscesses. This is kind of our go-tos. And then a lot of times they can broaden that on the floor if they're not getting a good clinical response from some of these treatments. It's been a minute since I've treated an RPA. I think I started with Unison on the last one. Is that what you're seeing?
Yeah.
Okay. Yeah.
That and then
same idea.
Dental abscesses, I think we talked about usually. Augmentin's going to be your go-to, or Unison for an IV version.
Or Clinda, like a lot of times they've already been on Augmentin, maybe, and had a failed outpatient treatment. They're coming in for IV, so we typically would switch to clindamycin on that patient.
Yeah, Clinda's a good backup because it covers the anaerobes, the basic gram-positives, gram-negatives that are kind of in your oral flora. So Clinda's a good backup for a lot of things.
Yeah, and it's a good option for allergies.
Yeah.
So in adults, we really avoided clindamycin. It's something that we kind of shied away from in large because of concern for C. diff. But we use it a lot in kids. Why is this different in kids?
So there's probably a lot of reasons. First of all, we don't have great options in kids, so it is one of the like all-encompassing, community-acquired, covers a lot. Maybe not great, but also might be enough. We don't worry about C. diff overall as much in kids. We do see it sometimes, but just not, people don't freak out as much in the peds world about Clinda and C. diff, whereas if our adult guys come over, they're like, ah.
Yeah.
And
it
then,
is gross. What did you say about it, Morgan?
Oh, I was gonna say it's a lot easier to find outpatient than some of your other options, and it tastes terrible though. But for some reason, I feel like we don't have a ton of kids that won't take it.
Oh, I've admitted a kid that wouldn't take it.
I would say it's high up there on the ones that like are bad, and we have kids that don't take it. But I've tasted it before, and I am shocked at some of the kids that will take it.
I smelled it and I said, oh, not tasting. We had a kid that we tried to give like an open capsule to, because that's an option if they fit within that dose range, where it's just like a spoonful of gross rather than a whole giant
20
syringe of gross.
Right.
And he kept vomiting that up, and then we're like, let's try the solution. And he took it down. He was like, that was fine. And we're like, oh, okay.
Okay.
So, solution for you, I guess.
But I hear rumors they're going to reformulate this. It's going to taste a little better. Have you heard that?
Supposedly.
Yeah.
I don't know. I've heard it for like a year or two,
Okay.
so we'll see.
All right. So sepsis.
Sepsis, I think most of the time these kids are going to come in like looking pretty cruddy. And so you're going to go very broad, and you can narrow as you get culture. So usually you're going to think Vanc and Rocephin, sometimes Zosyn and Vanc. We don't use that as much in kids as they do in the adult world, just because we don't have a ton of resistance. If it's a chronic kid that you know they've grown stuff before, looking at their cultures and figuring out kind of how you can narrow or potentially think about what is causing that infection. But I think the biggest thing is like sepsis itself is not an infection. It is a result of an infection that has gotten out of hand somewhere else. So thinking back to your ID man, do we think that this came from like a pneumonia that's progressively worsened? Do we think it was maybe a sinusitis that has moved into maybe a potentially meningitic infection that has then infiltrated the bloodstream? So thinking about what was the initial cause of the infection, and what are we thinking about treating now systemically in the whole body versus just in that one specific area.
Yeah, great advice. All right, we're not going to talk about Feb Neo because we actually did a whole podcast on this. If you're curious, our go-tos right now are ampicillin and cefepime for these babies. All right, abdominal infections. Let's just say we're going to treat somebody going to the OR. What are we treating with?
So you're going to want to cover anaerobes is the kind of main thing that should pop in your mind. So along with the wimpy MRSA theme I've been going with, we were also taught that wimpy anaerobes live like above the stomach, so in your mouth, whereas more serious anaerobes live below the stomach in your gut. So you're going to want to go with basically not clindamycin. So something that's going to be a little more serious coverage for those anaerobes. So as an example, like we see appendicitis all day long. Our non-perforation go-to is cefoxitin because it has that little random anaerobic coverage that the other cephalosporins do not. So usually we'll start non-perforated epis on cefoxitin. Whereas if the patient has a perforated appendicitis, we start Zosyn. So that is your like all-encompassing GI coverage, great anaerobic, your gram negatives as well. And then for some reason, if you can't use Zosyn and you need a serious add-on anaerobic coverage guy, it's going to be Flagyl. So Joe said he is number one. So Flagyl is number one for your anaerobic coverage. And that's really all it does. So if you needed to avoid the penicillins for allergy reasons, whatever, you can piece together coverage with maybe a cephalosporin and then your Flagyl to add that anaerobic coverage.
We had a kid recently that had a penicillin allergy that surgery wanted to start Zosyn on. The family was like very hesitant about it, even though it was like questionable and if it was an actual penicillin allergy or not. And so we ended up doing Rocephin and Flagyl. But yeah, I've always been taught above the diaphragm anaerobes is Clinda, below the diaphragm anaerobes is going to be Flagyl.
All right. I think we covered what we can in a podcast, right? We could go on and on and on about this. And I hope this was helpful for people that are newer to choosing these medications and navigating this. I think what Morgan said is the number one thing, right? So we're treating something bacterial, but think about where it comes from. And if you can just go back to this picture, you can print this picture, keep it in your resource list, and spend a minute thinking about what is the most likely thing that's going to be causing this, if it's in your head, if it's in your gut. And that's really going to help you narrow your search. And then, of course, your resources out there. The Sanford guy is an amazing resource for antibiotic coverage. There's also some ER guidelines as well. There's the EMRA app that is available that is designed for emergency medicine and choosing antibiotics, but then also Up to Date. That's a go-to here at Children's that we use a lot. So use your resources and get out there and make good choices for your patients. And
Use your pharmacist.
Yeah, use your pharmacist. So it's become second nature to me. I love it. I love that we have you guys in the hospital. You're both fantastic. Well, thank you, ladies. And we
Thank you.
See you next time, which is really the last time, but we'll finish up and talk about common meds we use in the emergency department on the next podcast.
Bye.
Bye.
Thank you guys so much for joining us here today on PEM Chat for the first of this two-part series with our clinical pharmacists. Now, they're going to come back for a part 2, but it's going to be in December of 2025. And at that point, we're going to talk about all the other medications we use in the ER. And that's going to be fun because if you don't work with kids, these are resources that you need to know about. How we give Decadron without giving a shot, how we use ODTs for Zofran in the majority of our population, how we sedate for sutures, little tips and tricks that you can implement in your practice wherever you are in the United States. Now, next month is a really special episode, so I hope you guys will all come back. And it is the 1-year anniversary of the PEM CHAT podcast, so I'm really excited about this one. And we're going to be talking about OB emergencies. Now, if you know me, you know that my history in medicine began in OB. I worked in OB for a really long time. But if you don't, this is something that's really near and dear to my heart. And I represent the AAENP as a stakeholder in an initiative with ACOG that was released last year, really to bring resources to ER providers about OB emergencies, and some of these emergencies you may not even recognize as an emergency. And that's why this message is really important. And if you're a pediatric provider thinking, I don't take care of pregnant women, well, think again. You are. You are taking care of pregnant and postpartum women who are at risk for these emergencies every single day. And we're going to talk about how to recognize this population and how to treat this population. So it's an episode you don't want to miss. I'm excited to see you guys next month. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast is designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.